Hey, welcome back to Pharmacology. Today we're going to be concentrating on the hypolipidemic drug. So we're going to be reducing cholesterol. In hyperlipoproteinemia, we're just going through the very, very basics of the disease first. We'll cover that a lot more in pathology. But in the primary cause, there's going to be a single gene defect, and it can be either monogenic or it can be familial. Most of the time, however, it's going to be multi-genetic and environmental. So there is going to be a multifactorial cause. So exercise, diet, lifestyle, along with genetics. In secondary, hyperlipoproteinemia is going to be caused by complications of diabetes, especially unmanaged diabetes, nephrotic syndrome, chronic alcoholism, and myxedema or hypothyroidism. Okay, so in type 1 familial hyperchylomicronemia is going to be a deficiency of the lipoprotein lipase or apolipoprotein C2. So this is going to be a problem with the liver. In type 2A, there's going to be a deficiency of the LDL receptor. So there's going to be a problem with sequestering the cholesterol into the cells. So there's going to be too much free cholesterol rolling around. 2B is going to be a familial combined hyperlipidemia. So there's going to be a problem with the receptors along with a hyperproduction of cholesterol. Type 3 is going to be familial beta lipoproteinemia, which is going to be a mutation in the apolipoprotein E gene causing a problem with this. So a problem with apolipoprotein E is going to be a problem with sequestering the cholesterol once again. In type 4, hypertriglyceridemia is going to be a decreased removal of VLDL or triglycerides. So too many triglycerides are going to be floating around. In type 5, it's going to be a mixed hypertriglyceridemia, which is going to be a problem with both the removal of VLDL and chylomicrons. So not only is there a problem with removal of the triglycerides in the blood, there's also going to be a problem with the transportation of the chylomicron in the lymph. Okay, so HMG-coenzyme A reductase inhibitors are going to inhibit the cholesterol synthesis rate-limiting step. So this is actually a very good drug. You stop the production of cholesterol like at the very beginning. So there is no wasted energy in trying to even produce the cholesterol, right? The bile acid sequestrants are going to be your resins and anion exchange resins. They are going to they're going to keep the cholesterol in the bile so it can be excreted. The activators of lipoprotein lipase are going to be fibric acid derivatives, and the name makes sense. It's going to cleave the lipase for energy, so using it up, reducing the amount of cholesterol in the blood. There are inhibitors of the adipocyte and the triglyceride synthesis in the liver, allowing more of the cholesterol to be used versus just being stored. Niacin is going to be your cholesterol absorption inhibitor. And omega-3 fatty acids are actually proven to reduce the amount of triglycerides and cholesterol in the blood. Not as much of these medications above, but like enough to keep you in good shape if you are borderline, right? And there are the PCSK9 inhibitors. So the HMG coenzyme A inhibitors are your statin drugs. These are your competitive and reversible drugs, and they decrease the cholesterol synthesis right here. So they're going to inhibit HMG coenzyme A reductase. Here are the examples. The ones that you need to be paying attention to is atorvastatin. The adverse drug reactions are pretty bad. These you have to monitor carefully, because there's going to be muscle pain, rhabdomyolysis, problems with the kidneys, so increased creatine kinase, but more importantly, hepatotoxicity. So this can influence the liver quite adversely, along with fetotoxicity. You can't be giving this to pregnant females. Simvastatin is going to be metabolized by cytochrome P450, 3A4, which can increase the risk of the rhabdomyolysis. Rhabdomyolysis is the breakdown of the muscle, and it's going to manifest as bloody urine, right? There is also going to be an increased effect of warfarin, a blood thinner. So it makes the risk of warfarin toxicity a lot higher. So the statins do work by simply reducing the amount of cholesterol made. And in doing so, it decreases LDL and the triglyceride and increases more of the HDL. So the statin are not going to be effective in the homozygous familial hypercholesterolemia, because this is going to inhibit the cholesterol synthesis, but there is still a problem with the LDL receptors. So the bile acid sequestrants are going to be your resins. So first were your statins, now is your resins, and these are going to be cholestyramine, cholestyramine, and cholesevelam. And it decreases the bile acid absorption and increases the hepatic conversion of cholesterol to bile acid. So without the bile acid absorption, you need to make more. So the cholesterol, instead of being left in the blood, is going to be converted. So you can use this quite well with statin. So statin is going to inhibit the cholesterol formation at HMG reductase, or coenzyme A reductase, and then this is going to use whatever's left over. So like cholesterol's already high, right? So the first one, it doesn't necessarily reduce. The statins don't necessarily reduce the amount of cholesterol actively. It just stops more production, right? So whatever's left, we're going to use the resins in order to bind them to the bile for the body to excrete. Once again, it's not going to be effective in homozygous familial hypercholesterolemia because they're not affecting the receptors. Okay, so gallstones is an obvious adverse drug reaction because you're making more bile, right? And cholesterol and bile, you make the fatty gallstones. Another complication is that triglycerides and cholesterol is going to be necessary to absorb fat-soluble vitamins along with the bile acid. So if there isn't as much bile acid being produced or absorbed, there's a problem with absorption of the fat-soluble vitamins. So by doing that, there's going to be GI intolerance, so diarrhea, cramping, nausea. The triglycerides aren't affected by this, so it can increase. And the problem is, without the absorption of the bile, there's no absorption of the fat, there's going to be decreased absorption of other fat-soluble drugs. Fibrates are going to be gemfibrozil and phenylfibrate. ApoA1 synthesis in the hepatocytes are going to increase HDL. They increase the lipoprotein lipase in the vascular bed, so there's going to be more lipoproteins used, right? So more cholesterol is going to be used. And it decreases the ApoC3 synthesis. So we're going to use the fat and the triglyceride and the cholesterol for energy. We're not going to store them in adipocytes. The fatty acid oxidation in the hepatocytes will decrease the triglyceride synthesis, and they stimulate the PPAR alpha. And by that, it will increase the lipoprotein lipase in the vascular bed and decrease, like I said. So in doing so, it's going to decrease the plasma triglyceride. The adverse effects or reactions are going to be GI problems, gallstones, myalgia, and from the rhabdomyolysis, and hepatotoxicity. Niacin is going to decrease lipolysis in the adipocytes, and in doing so, it's going to decrease the production of VLDL in the liver. It's going to decrease the clearance of ApoAI from the plasma to increase the HDL. And the adverse drug reactions are going to be in your rash, your gout, because there is the decreased clearance of the ApoA1 that's used to clear uric acid as well. And an important problem is the hyperglycemia. So it is a very effective HDL increaser, and it also decreases LDL and triglycerides levels, but this hyperglycemia you have to be careful with. The cholesterol absorption inhibitors, such as ezetimibe, is going to selectively inhibit the absorption of the cholesterol in the intestines. So niacin and atorvastatin are going to decrease the lipoprotein A concentration. And these are going to be contraindicated in the hepatic disease. Why? Because niacin has the hepatotoxicity, and atorvastatin is going to affect HMG coenzyme A reductase, which is in the liver. So in liver disease, it's already malfunctioning. You don't want to add something to increase the oxidative strain. Lomitapide is going to inhibit the microsomal triglyceride transfer protein to decrease the amount of VLDL. Mipomersin is going to change the antisense oligonucleotide targets ApoB100 to decrease LDL. This is more of a DNA or steroid kind of mechanism, and because of that, it's going to decrease the familial HCl, because these will work on the receptors. Okay, so omega-3 fatty acids are eicosapentaenoic acid and docosahexaenoic. Oh, excuse me. Wow, that kind of took me out of nowhere. Acid. So this is going to be a 20 amino acid chain. I think this is 10, but they are very large, long chain fatty acids, and they're going to decrease the plasma triglycerides. How does it do that? It's going to convert the fatty acids into DHA by regulating the nuclear transcription factors, and cause reduced triglyceride biosynthesis. Is going to increase the fatty acid oxidation in the liver. So the PCSK9 inhibitors, alacrocumab and evolucumab, are going to inhibit the transport of LDL to liposome for degradation. So these are monoclonal antibodies, and they're going to target the transport LDL. So the LDL is going to be degraded and kept from the plasma. These are not super popular in a clinical practice because they are so expensive. Okay, so just as a review, the statins are going to be HMG-CoA reductase, going to decrease LDL the most. It's going to somewhat increase the HDL and somewhat decrease triglycerides. Fibrates are going to mostly work on decreasing the triglyceride. Niacin is going to increase the amount of HDL, but it's going to also decrease the triglyceride. The bile acid sequestrants are going to decrease the LDL by allowing it to be excreted, and it will somewhat increase the triglyceride though. So this you have to use in tandem with something else that decreases the triglycerides. So using this with fibrates, it's a good deal. The cholesterol absorption inhibitors are unfortunately kind of the least efficacious of all the drugs. So they'll somewhat decrease the LDL, somewhat increase the HDL, and somewhat decrease the amount of triglycerides. So in somebody with only like borderline, this is a decent drug. That's it for now. Thank you for your attention and good luck studying.